prevent mechanical complication for central line insertion. So what do you suggest how to prevent this, Dr. Viet?
Practice, practice, practice. The
Exactly.
more experience that you can get, certainly the smoother these procedures will go. Mm-hmm. Never ever be afraid to ask for help if you feel like you're in over your head. Mm-hmm. Try not to get in over your head initially. Always have backup if at all possible. This directly correlates back to why emergent situations carry with them a higher grade chance of the risk of mechanical issues with the procedure. So call for help if you need it. Secondarily, as I think we mentioned, standard of care now in the United States, use the ultrasound machine. In the old days, surgeons would regularly do subclavicular, central lines just with anatomic landmarks. Mm-hmm. Can be done. You'll meet older physicians that do that, but currently, and again, for license sake, standard of care is use of ultrasound. Certainly helps. Finally, with a difficult insertion, you'll run across those that just are not going to happen. The attendings tried, residents have tried, and it's not working out. In that case, certainly consider a PICC line. That's something that's available practically everywhere, and nurse insert it. Okay. So carries with it its own set of issues outside the scope of this discussion.
Yeah.
But those would be my 3 suggestions.
All right. So I think those are the common suggestions that you can prevent mechanical complication. Now another question is, so what are some common mechanical complications and how do you manage them? So I think there's a couple of them and we would like to discuss with you today. Number one, if you puncture into an artery, so arterial puncture. Mm-hmm. Secondly, that's bleeding, that's obvious. And then the last one is pneumothorax. I'm sorry, one more, not the last one, it's air embolism. So can you just tell us a little bit more about what happened?
Right, the residents' most feared
if you
occurrence.
Hit an arterial versus a vein you're supposed to go to. All right, and so what are the symptoms? What would you tell if you hit an artery versus a vein?
So the first question is, how do you know?
Exactly.
Arterial versus venous blood. It's pretty obvious. First off, it's usually, assuming the patient's not badly respiratorily compromised, bright red, fire truck red, versus the darker, bluer look that you have with venous blood. That's not as reliable as the fact that arterial blood, unless you have someone with an incredibly low blood pressure, is pulsatile. It is flagrantly pulsatile. You will know when you're in it because blood will be squirting out of the back of your catheter. You do not see that. It's a trickle usually, even possibly, maybe a vigorous trickle, but with venous blood, it is not pulsatile. Also, if in doubt and you still don't have a strong indicator, the waveform with transduction will look different, and you'll certainly be able to tell from the waveform.
Yeah, so as Dr. Viet mentioned earlier, you use ultrasounds, and this is one way to confirm this is arterial versus venous. You look for the wave, and as they mentioned, that you can see that pretty clear, a typical arterial waveform. So how about bleeding? So what would you see on bleeding?
Generally speaking, if you do access or puncture the artery, it's not a catastrophe. It's certainly something discouraged, but it usually doesn't result in a terminal event. You want to hold pressure, certainly. Because of the pressure the artery is under versus the vein, certainly you will have a hematoma formation. That may be visible exteriorly, it may not, although it probably would be with ultrasound. But you discontinue the procedure and you hold pressure on the site for at least 3 minutes, depending on the site.
Yes, and so another thing is common. You see, when we do subclavian or sometimes IJ, you can have something called hemothorax, So what would you comment on this, like what you usually see on the hemothorax?
It presents very much like a pneumothorax clinically.
Yes.
You can see shortness of breath.
Uh-huh.
You may see some changes on pulse oximetry.
Uh-huh.
The patient may cough. The patient may also complain of chest pain to that area. And primarily those are the indicators.
Yes.
And then you would order a
Chest X-ray.
Absolutely.
The key thing about hemothorax is if you insert on the right side and you have patient with shortness of breath, and then you see a pleural effusion on the left side, which is not likely from this because it's hard for blood to go from here to here. However, if you see shortness of breath, you insert on the right side, and then on the same side that you see pleural effusion, then you may wonder, could it be a hemothorax?
Yes.
It's likely it is.
Yes.
And then the very common is, another thing is pneumothorax that you mentioned earlier.
Yes.
So you mentioned symptom already, like shortness of breath, and sometimes it could be asymptomatic. This means there's no symptom, symptom at all, right?
Yes. It has to be a fairly large, I think greater than 50 cc's
Exactly.
of air for it to be symptomatic.
Yes, because most of the time when we see pneumothorax, the small patient have no symptoms.
Yes.
So this is something that you keep in mind. And the last thing is air embolism. So how would you comment on this, Dr. Witt? What is the typical presentation with an air embolism?
They can be very wide-ranging, actually, from asymptomatic to presenting in a way similar to a PE. Acute onset of respiratory failure is certainly the most alarming feature. With that, you would see likely chest pain, possible cough, and certainly a decrease in pulse oximetry on that patient. Usually the respiratory rate will go up, and with variable depth. You may see some asymmetry of chest rise also, although that would be less likely. That would be more consistent with pneumothorax, which could coexist, actually. There was an overlap, we should mention, of all of this symptomology.
Yes, of course. Sometimes complications that happen are not just one. Just like they say, luck usually comes as one, but unluck usually
bad luck comes in threes.
So that's what they always say. And then the patient, of course, you want to place in the Tran position. By the way, because you do in anesthesiology, what is Tran position? So if you so by doing push the patient back on the Tran position, so hopefully people can prevent the air bubble from entering the ventricular outflow.
Yes,
right.
Yes. You want the air to go towards the ceiling.
Yes.
And the feet to go towards the ceiling.
Exactly. So that's what we meant by
Tran, certainly.
Okay. So I think that's it for the discussion about the mechanical complication and how
you should mention chest tube.
Oh, that's right.
Yes.
Yes.
With both hemo and pneumothoraxes.
Yes.
If they are readily symptomatic and an impairment in the patient's respiratory status, a chest tube should be ready and inserted to remove either the blood or the air and allow the lung to re-expand.
Yep. That's a great comment on that. So we, in the next section, we stop our discussion here, but our question for you is now we talk about subsequent complication of infection. How would you prevent them, and what are the interventions for subsequent complications, infection? That's what we're going to discuss. So thank you very much for your today.
Thank you, Dr. Tran.
Coming.
It was a pleasure.
And then share with us your expertise and tips on how to do this. So hopefully we hear more from you, and we would like to see what you think on the VietMD.net. And again, my name is Dr. Tran. This is Dr. John Witt I'm the president of VietMD.net. Thank you very much.